Good evening, everyone. Thank you so much for joining us. This is our Derbyshire Education Network session and also First Five joint session. And we are covering dry eyes in primary care. And Indy's very kindly going to do a few other common eye conditions she was mentioning today. So yes, it should be a really great session. It's something that we all see very commonly and sometimes is a bit tricky. And we've got Nisha here as well because it's being sponsored by iScope. And just to say, there's other sessions coming up with Den and First Five, and we'll just remind you about those at the end. As usual, bit of housekeeping. So if you have got any questions, Indy's very happy for you to unmute and just ask them as we go through. But if you just want to pop them in the chat, that is fine too. If you would like to put your camera on, that is lovely, because then we know you're here with us. But if you're having your tea and you just want to have a little chill, that's fine too. And you are automatically muted when you enter. But if you would like to ask your question, as I said, just unmute and get involved. So without further ado, can I hand over to you, Nisha? Is that all right?
Okay, well, evening, everybody. My name is Nisha Badwell, and I'm the Healthcare Development Manager for the area from Scope Eye Care. And with me, we've got Inderpreet Apal, who's the Optometry Professional Affairs Liaison, who'll be delivering a talk on diagnosing and managing dry eyes in primary care and when to refer. So before Indy does her talk, I'm just going to run through with you the Scope Eye Care range that we have for the management of dry eye disease. You may already be familiar with the high-low range. So you can see we've got quite a few different ones here where we cover different severities of dry eyes. But what all the high-lows have in common is that they are all preservative and phosphate-free. They all have a 6-month sterility. They all have 300 drops in a bottle, and they can all be used with contact lenses. And you can see how they all use sodium hyaluronate, which is the gold standard lubricant that's naturally found in our bodies, and it's what gives high-low its viscosity and lasts a lot longer on the ocular surface. So with the high-low range, like I mentioned, we cover different levels of dry eyes. So when a patient first presents with dry eyes, they commonly get put onto something like hypomellose, which has got preservatives in them, and it's very watery and it doesn't really lubricate the eyes. And a third of patients don't tolerate hypomellose. So for those patients with mild dry eye, you consider high-low fresh, and it's for those who need to be using drops once or twice a day. Or if they've got any redness of the eyes, it also has euphrasia, which reduces redness of the eyes. So high-low fresh is for mild dry eye. And for anybody who suffers with moderate dry eye, where they need to use drops 2 to 3 times a day, we've got high-low tier. And then you can see the concentration of the sodium hyaluronate goes from 0.03% to 0.1%. So that's for moderate dry eye. And for severe dry eye, which you're probably more familiar with, we've got high-low forte, which is 4 times more viscous, and it's got 0.2% sodium hyaluronate. And then we have high-low dual, which is for lipid deficient dry eye. If anybody suffers with Meibomian gland dysfunction, or if they have allergy related dry eye, then we've got high-low dual, which you can see contains another ingredient called ectoin, which is a natural molecule, and it works by creating a barrier on our tear film and prevents allergens reaching the eye. And as we are in the allergy season, it's worth considering high-low dual for those patients. And then you can see here we've got high-low care, which is for those who cause any corneal injuries, abrasions to the eye. And high-low care contains dexpanthenol, which is a provitamin B5, and that helps to heal the eye without any scarring. So high-low care is for regeneration for anybody who's caused any corneal injuries. So you can still treat them within the community before sending them to the hospital. And you can see at the end here, we've got high-low night. A few years ago, we used to be called Vitapos. A few years ago, we did a rebrand where we changed it to high-low night so it fits with the rest of the range. And with high-low night, it's paraffin-based, so it's a nighttime ointment, and it contains retinol palmitate, which is vitamin A. And what that does is it lowers the melting point so that when it's on the eyes, it clears within 10 to 15 minutes. So it doesn't sit on the eyes, causing blurry vision like most other paraffin eye ointments. And for patients who suffer with moderate to severe dry eye, they would benefit from using a nighttime ointment so that they don't wake up with really sore, dry, gritty eyes. So hyalo night is for nighttime, and it's the only one that should not be used for contact lenses. So that's the hyalo range. And I'm just going to move across to our prescription, our POM range. And what we have is ketofor, which is for seasonal allergic conjunctivitis. So with ketofor, ketotifen, it's a preservative-free, like the hyalo range, but it has a dual mode of action where it works as an antihistamine and a mast cell stabilizer. So as soon as patients take it, it works within a few hours and has a long duration of action. The great thing about ketofor is they do not need to start it weeks ahead of the allergy season. As soon as they take it, it will work within a few hours. And it's twice a day, as opposed to 4 times a day, like other treatments. So it's twice a day, and it has a license from 3 years plus. So it's much more easy and practical, especially for children to take. And it's preservative-free as well. So ketofor is available for those who suffer with seasonal allergic conjunctivitis. That's just some information on the summary product characteristics. And then finally, in January, we launched into glaucoma, where we've got now a branded generic called BIMI. It's bimatoprost, and it's for those who suffer with glaucoma. So it's there to reduce intraocular pressure in chronic open-angle glaucoma and ocular hypertension in adults. And it can be used as a monotherapy or in combination with beta blockers. So with BIMI, bimatoprost, it's available as a 3 ml bottle, so a 3 ml multi-dose bottle, or a 9 ml bottle. So the choice is there for whether patients want to carry on with the treatment that's 1 month supply, or the choice is there for 3 months, where it will last for 3 months with the 9 ml bottle. And what that does is it will help reduce the need for repeat prescriptions. But it's also preservative-free. So it allows for preservative-free prescribing without the need for single-dose units. And with single-dose units, you have a lot of plastic wastage. So with the multi-dose bottle of BIMI, it reduces that plastic waste, and also preservative-free. So it reduces any long-term complications that are associated with preservatives. So BIMI bimatoprost is available for those with glaucoma. And just some information there on the summary product characteristics. And we just need to include a slide with any adverse events reporting, some information on there. And then just finally, if anybody wishes to request for any samples or product information on anything that I've just covered, then feel free to take a note of my details there. So I've got my email, my telephone number, and I'm more than happy to arrange that for you if anybody wishes to have any samples of the hyalo range or any further information.
So hi everyone, thank you for joining us. I'm sure you guys have had a busy Monday, so thank you for joining us here in the evening. So my name's Indy Ortinsbury. I'm an optometrist who works as part of the medical team for Scope, and I also do a couple of days in community clinic as well. So we see a lot of dry eye, but a lot of other weird and wonderful things that me and Lisa were discussing before you guys joined us as well. So today we're going to be discussing about diagnosing and managing dry eye in primary care, how to fit that into your ever so busy clinics as well. So we're going to start off with having a look a little bit about the eye, which is important. So we're going to cover a bit about the anterior eye. So the anterior eye is a very, very fragile structure. I've got a little diagram there of the front surface of the eye. So you've got the eyelids there, just there, and you've got the cornea, which is sitting underneath as well. So the cornea is really fragile, and the idea of the eyelids is to protect that cornea. The cornea has about 70 to 80 nerve fibers in comparison, and in comparison your arm has about 5. So it's really densely innervated, really, really fragile structure that we're trying to protect here. And that is really the main function of the eyelids as well. And the eyelids are sort of protection alongside with the tear film as well. The tear film, its whole idea is to protect that corneal surface. We've got little glands as well, which sit inside the eyelids. And the idea of that is to help produce a lipid, which is what we call Meibom, that we'll go into in a little bit more detail, to basically help stick the tears onto the front surface of the eye as well. So what's behind the lid? So we've got the tear film. So we've got the mucin layer, which sits closest to the cornea, the sticky layer, which really binds across the cornea. We've got the thick aqueous layer in the middle, so the watery layer that you've got. and then we've got the lipid layer at the top, and that's what's produced by those eyelid glands that come out as well. So we've got 3 layers. Evidence now suggests that it's more sort of a blend, so it's not as much 3 distinct layers, but they all sort of morph into one another to create this really beautiful, nice tear film as well. The lipid layer is basically there to lock in all the moisture, because we don't want to have the evaporation of the tear film as well. So the tear film is really, really important to the front surface of the eye, the whole surface of the eye, really. So 65% or 70% of the refractive power of the eye is actually made up by the tear film. So a lot of what we see is governed by what is on our tear film as well as having other functions as well. So it's the lubrication, it's helping to provide oxygen to the cornea, because our cornea doesn't have any blood vessels. So the tear film and other things are contributing towards the oxygen layers as well. Flushing away all those contaminants, all that debris, all that foundation, all that mascara, all the things that go into our eyes. Our tear film's there to lock that in and get that away from our cornea, and helping to prevent infections as well. So that's the tear film. So let's have a look into what is dry eye as well. So dry eye is really quite common, more common than we would maybe think. So roughly it's in about 12% of the population globally, which is actually a massive number if you extrapolate that and you have a look at that from the worldwide population as well. So having the correct diagnosis and management makes a really, really big difference to our patients' quality of life as well. What we look at here at Scope is the research, and there was some research done a few years ago, I think it's about 5-10 years ago now, called JUICE 2. And this is a dry eye workshop where 150 clinical and research-based specialists specializing really in the field of dry eye took 2 years, and they basically went and had a look at how they diagnose and manage dry eye in their countries. So from 23 countries, they compiled this research paper to basically give us what we call like a dry eye Bible, and tell us how to diagnose and manage dry eye disease as well. You can have a read of it. I think the full article is about 600 pages, but don't worry, there's a 12-page summary that I've put on a little QR code for you there if you're interested about knowing a little bit more. So they had a 2-year clinical effort. Majority of that effort actually went into diagnosing dry eye, because the definition of dry eye disease. It took them so long, these 150 people, to come up with a cohesive definition basically for dry eye disease. That's how really complicated it is. So this is the definition that they came up with in the end. That took them 2 years. So it's quite a lengthy definition, but we're sort of going to break it up a little bit. So they said that dry eye is multifactorial, so it comes with a lot of different factors, some of that we'll go into. It causes a loss of homeostasis, so a loss of that balance to that tear film, and it has ocular symptoms, which patients will feel, and you ask in history and symptoms. And it causes hyperosmolarity, so to do with those salty tears, that imbalance in the salts in the tears, and it can lead to ocular surface inflammation and damage as well. So it's quite a lengthy definition there. It's quite complicated, as dry eye disease, and it affects so many different people. It affects hundreds of millions of people around the world, and it's actually one of the most frequent causes of patient visits to eye care practitioners. So you'll see it quite commonly in your clinics. I see it very commonly in my clinics as well. I've put a few stats here which are a bit interesting. When you think about dry eye disease, you don't necessarily think of it having such an impact on your patients' lives, but it has such an impact on different parts of their lives. So poor visual performance whilst driving, depression and anxiety is actually more prevalent in patients suffering with dry eye blepharitis. It has a significant drop on quality of life, on par with angina. That was a really interesting research paper done, where they basically asked a bunch of patients, how many years are you willing to sacrifice to be able to be disease-free for the rest of your life? And the patients with dry eye disease actually said the same amount of years as the patients with angina. And we associate angina with being very debilitating. And that's how significant dry eye disease has an impact on our patients' lives. And 3 in 10 people actually suffering dry eye disease will experience symptoms for more than 6 months before seeing, your GP, you guys. So they let it get to such a point that, they get it to a point where they're so fed up with it, and then they're happy to go see someone about it. So at that point, they're so sick of it and they just want a solution to it as well. So there's different subtypes for dry eye disease. That's not really too necessary, but we'll sort of have a brief overview of it. There's 2 broad categories, aqueous deficient and evaporative, and that's to do with that, those 3 layers of the tear film. See, aqueous deficient is more to do with lacking in that aqueous component of the tears, more common with Sjogren's symptoms, and your evaporative is to do with more the lipid layer and the evaporation of the tears generally. But most of dry eye disease is a combination. So it's a combination or evaporative dry eye. It's very less common in aqueous deficient dry eye. So you don't tend to get more aqueous deficient dry eye. It's more a combination or evaporative dry eye. Aqueous deficient is more found in sort of Sjogren's disease. And the sort of combination of evaporative dry eye is more linked with blepharitis and Meibomian gland dysfunction. So that these are causing factors for your dry eye disease. Blepharitis and MGD are causing factors for your dry eye. So what is blepharitis? I think Elise was saying roughly that you guys see quite a lot of blepharitis in your clinic. So we'll cover that. So blepharitis is inflammatory. So I've got a brief little picture there of blepharitis. So you can see sort of the scales on the lashing, the crusting, and it's an overload of that bacteria. So we all have natural flora as humans, but the bacteria is an overload of that bacteria that's going on there. And it's a chronic condition, so patients can manage it. Oftentimes, if a patient comes in to me and I say, look, you have blepharitis, blah, 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 this is what you need to do, they'll go away, do it for a couple of weeks, and then come back and say, I did it, it worked, but now it's come back, because they don't understand that it's chronic and they have to continue with the regime that you give them. Otherwise, all the symptoms will come flooding back for them as well. And that's sometimes hard for our patients to come to terms with, that that's something that they have to continue. And it's definitely something that we have to reiterate as practitioners, that, look, you need to keep doing it. And it's one of the things that they don't always understand. And it takes quite a few goes for them to understand that. Blepharitis is actually one of the most common reasons to cancel like cataract surgery. So with blepharitis being an overload of the bacteria to the normal eyelids, if you've got that on your eyelids and then they're obviously cutting away at the cornea to get to do the cataract surgery, that's a major risk for infections and especially endophthalmitis. So if they've got blepharitis, consultants will cancel the cataract surgery until they've got that blepharitis under control, just because it's not worth the risk of the cataract surgery and doing that and then causing endophthalmitis. And then we've got Meibomian gland dysfunction, and that's to do with those glands on the eyelids, and they can become blocked, or they can just have really poor quality lipid inside of them as well. The way that the lipid is expressed is through blinking. So if your patient's not blinking properly, or the lipid inside is really poor quality, it's really hard for that to be produced. And again, that all causes symptoms of dry eye disease as well. So we have quite a few risk factors for dry eye disease. So we're just going to cover actually a few of them. So this is not an extensive list, but these are some of the risk factors that you'll see with your patients with dry eye disease. So like everything else, women get the short straw. So female gender is also one of the risk factors for dry eye disease, possibly because HRT is also a risk factor for dry eye disease. So it could be linked to that. Also to do with decreased blinking. Everyone's on computers all day, every day. If you're not on a computer, everyone's on their phones. It's normal. But decreased blinking is an increased risk factor for dry eye. Just as I said earlier, the Meibomian gland dysfunction, that oil that's produced through blinking. And if you're not blinking, that's all getting clogged up and therefore causing your dry eye disease as well. So it's important for those patients to be blinking as much as possible. Systemic diseases such as Sjogren's, lupus, rheumatoid arthritis, all risk factors, they're all inflammatory conditions, just like dry eye is an inflammatory condition as well. A lot of medications also are risk factors for dry eye disease as well. So antihypertensive, antihistamines, antidepressants. Obviously, we can't remove patients from medications, but it's just really important to know what medications are causing dry eye disease as well. And also omega-3 fatty acids as well, so a low intake. So normally what nutritionists prefer, what we should really have in our diet is a 1-to-1 ratio between omega-3 and omega-6 fatty acids. But in Western diets, we have probably a 1-to-6 ratio. So it's not a great ratio. So increasing those omega-3 fatty acids can really help with those dry eye disease symptoms as well. It might not solve it all because there'll be other risk factors contributing towards it, but it will help patients with their symptoms as well. So I've got this little chart here, a little checklist on medications that can cause dry eye disease. So there's many antidepressants, antihistamines, some of the ones that we talked about earlier. So it's important because obviously we can't remove the patients from any of the medications they're taking, but could we be having more, say, a proactive approach to, could we be prescribing dry eye drops when we're prescribing some of these medications as well, especially if they've got other risk factors? So for example, if you've got a patient who's female, they're taking, you know, medications, they've got other medical causes, they've got Sjogren's or rheumatoid arthritis, should we be prescribing eye drops to go alongside it, or should we be at least making them aware that, look, this might happen, you might experience symptoms of dry eye disease, if you do, let me know and I can prescribe you some drops. So just so that they're aware, so they're not sort of taking medications and then they're thinking, oh, hang on a minute, this is causing me problems, just so that they're aware of that, really.
Sorry, Indy, could I just ask a question?
Go ahead, yeah.
Do you know, you're talking about dry eyes can be part of Sjogren's or lupus. I know you do the clinics in the community. Have you ever picked up that as a kind of first sign of someone's condition and had to kind of refer them back to GP? Or have you really just seen it as someone who already knows they've got the condition? I just wondered from your point.
Yeah, no, we see it a few times. So especially with Sjogren's. So Sjogren's, they'll have like a dry mouth, just generally sort of dry. And dry eyes. So yeah, we pick it up as a factor and then refer into the GP and say this patient's got dry mouth, dry eye, symptoms like that. And it could be, yeah, the reverse. So you're able to pick up conditions from seeing the dry eye. Yeah, so definitely.
Oh, brilliant. Thank you.
No worries at all. So dry eye disease is one of those things that once you get onto the merry-go-round, the vicious merry-go-round, it's really hard to get them off it. So the earlier that you get them off the cycle, the better it is, the better the outcome, the better their symptoms will be as well. So the more proactive we can be diagnosing it earlier, the better really the patient outcomes, the less chair time for you guys as well, because they won't be coming back as much as well. Some of the symptoms for dry eye disease, you guys will probably have seen some in clinic. Do you know some of the symptoms of dry eye disease? What is one of the common ones that you see in clinic when patients come in, you know, complaining of dry eye disease?
The thing sometimes people say to me is that they their eyes are watering a lot.
Yeah, normally when they're going for a walk in the wind. Yeah, that's a common one. I think that's probably the most common one even I see in practice. So you'll get fluctuations in the vision, sore eyes, contact lens discomfort. Watery eyes is a good one. Watery eyes majority of the time is linked to do with Meibomian gland dysfunction, because you've got that lipid layer which isn't too great. The tears are evaporating and then the brain's telling the eyes, look, create me more tears, make me more tears, but they're not the correct sort of tears. So the patients are what we call reflex tearing, and that's what they're experiencing when they go for a walk in the wind, or just generally their eyes are just constantly streaming. So it's a really key factor for Meibomian gland dysfunction is the watery eyes. And eyelids difficult to open in the mornings, as well as it is a really important one. So to diagnose dry eye disease and exclude the conditions that mimic it, we've got a few sort of triaging questions that you guys can ask as well. So how severe is the eye discomfort? With dry eye disease, it doesn't tend to be sort of completely, you know, severe pain, then, you know, cutting over with pain. It's normally just severe discomfort. You know, they can manage it, they can sort of get around with it. So if you're thinking, if you've got a patient with really severe eye discomfort, you know, severe eye pain, that's not really dry eye disease. You should be thinking other things there. Any mouth dryness, so just this one. So if we've got a patient with dry eye, I normally do say, look, do you have any mouth dryness, just to see if that's a trigger then for the Sjogren's symptoms as well, because then we can sort of diagnose that backwards, if that makes sense. And then how long have your symptoms lasted, and was there any triggering event? Normally dry eye disease doesn't come on really suddenly. It's a slow, really gradual change. If you've got a patient and they say, look, my symptoms started yesterday and it's quite severe, and I was doing the gardening and I might have got something in my eye, not really dry eye disease. So it's really important that you ask them if anything's triggered it, because that could really point you in the correct direction on if it's dry or if it's not dry eye. Is your vision affected, and does it clear on blinking? This is a really good one. I always tend to ask my patients this one, because if it's dry eye disease, normally it will clear on blinking, and then it will get worse as after the longer between blinks, the vision might get a little bit more blurred. But when they first blink, it does clear first as well. Are the symptoms or any redness much worse in one eye than the other? Normally dry eye is equal and bilateral. So if they've got sort of severe redness in one eye and completely clear on the other side, or sort of very varying, then think other things rather than dry eye disease as well. Do the eyes itch, swollen, crusty, any discharge? Itchy eyes, possibly more sort of allergic conjunctivitis. You're thinking if they're constantly itching them. Are they swollen or crusty? Could be blepharitis, but you might be thinking sort of bacterial conjunctivitis as well. And any discharge, again, if there's, you know, mucopurulent discharge, you're thinking more bacterial conjunctivitis there as well. And contact lens wear. I think contact lens wear is a really important one, because if they wear contact lenses and they're coming in with a red sore eye, it could be an ulcer. So that's a red flag there for your ulcers as well. And have you been diagnosed with any general health conditions, including recently respiratory infections, or are you taking any medications to help you then put you in the correct direction as well? So once you've asked sort of all those triaging questions, you go in and have a look at your management as well. And it's all about breaking that vicious cycle. It's, you know, really striking that balance with your patient to see what they can do, how you can help them, and just bringing back that balance to that tear film as well. So if you come back to that research paper, sort of the JUICE 2, they recommend a regime including lubricants, lid hygiene and heat, and preservative-free. Recommend preservative-free because preservatives can be very toxic to the front surface of the eye. So preservative-free is best with our patients with dry eye disease, because the last thing we want to do is add preservatives to a surface that is already compromised, it's already dry, that's already really sore. Adding preservatives to that will make it even sorer for the patients as well. So we recommend a regime of heat, cleanse, hydrate, and also to have a look at supplement, help supplement their diet as well, looking back to sort of the omega-3 fatty acids as well. So let's have a look at heat. So we want to make sure that that meibom, that oil, that lipid in those lids is like an oil. We don't want it to become like a butter. Sometimes that can happen if they're not blinking enough. So what we'd recommend them to do is use a warming mask on a closed eyelid to melt that. And then afterwards, we recommend gentle rolling motion towards the lashes. So just rolling in at the top and rolling up from the bottom to help basically move all that sort of stagnant oil all to the surface, to blink it out a little bit to help them move that a little bit more as well. And then cleansing, it's important to get rid of all the dirt, debris, especially with blepharitis, because it's an overload of that bacteria. We want to make sure we're getting rid of that sort of surface bacteria just to get them down to that normative level of their natural flora of their eyelids as well. So recommending a specially formulated lid cleansing product as well. And again, preservative free, because we don't really want any preservatives near that delicate eye area. I've put a baby shampoo there and a little X. Does anyone recommend baby shampoo to help remove blepharitis? You guys come across that before?
Yeah, I've definitely come across it before. I think I've seen it in patient leaflets as well.
I'm sure I did as well. I'm sure I heard this from an ophthalmologist.
Yeah, it's one of those things which was actually quite commonly recommended, just because we didn't really have anything better on the market. So baby shampoo is a detergent, so it's great at getting rid of the bacteria, but it's also great at getting rid of oils, and that's the last thing we want to do with that oil in the tear film as well. So we don't recommend it anymore, the baby shampoo, because we know it strips away that oil. So it does a great job of getting rid of the blepharitis, but it wreaks havoc with the tear film, which is the opposite of what we want with a dry eye patient. So those are the specially formulated lid cleansing products, which will do the same thing as the baby shampoo in terms of getting rid of the bacteria, but it will just make sure that that tear film is still stable as well. It's always a difficult one when an ophthalmologist recommends baby shampoo, because it's really hard to contend with that, because they're dealing with the eyes. But in terms of patients' best interest, baby shampoo is one of those ones that we don't recommend anymore, because research has suggested that it's not needed anymore, and it's actually prescribed off license as baby shampoo, whereas this is a formulated lid cleansing products which you could prescribe on license. And then coming to the hydration, so we need some sort of hydration, some sort of lubrication to basically balance out the tear film. And again, we want to make sure that's preservative free, not adding any preservatives in, and adding in hyaluronic acid. Hyaluronic acid is a great product. It holds 1,000 times its weight. It's really high in terms of its moisture retention. And also it's naturally found in our joints, our connective tissues. Sorry, Kareem, you've got your hand up there. Do you have a question? Oh, I think you're on mute.
It's about still understanding how to get to the diagnosis to begin with, because all the symptoms seem a little bit slightly overlapping. Is this picture? Is this using? Is the picture you got on your slide?
On the bottom left, yeah.
Is that actually? If you use fluorescein, should it look like that?
Yeah. So this actual picture is actually to do with preservative toxicity. So this was a patient that came in that was using glaucoma drops. So glaucoma drops which were actually preserved, and they were then using hypomelos, which then has preservatives in it as well. So all those preservatives cause this toxicity to their epithelium of their cornea, and then you'll get all that sort of punctate staining. So yeah, definitely seen eyes like this many times. It's because they're adding so many preservatives into the eye, it's causing that toxic effect. But the great thing about patients like this is once you remove them off all the preservatives, the cornea has great healing capabilities. So about 24-48 hours, it all gets back to normal, and it's the preservative which is causing the toxicity there.
Okay, thank you very much.
No worries at all. Yeah, so that's why it's really important to make sure that the drops that you're recommending is preservative free, especially for those patients which are already on other drops like glaucoma drops which are preserved. The last thing we want to do is add another preservative into that as well.
Indy,
Yeah.
can I ask a silly question?
Yeah, sure.
Why do they have hydrating drops then that do have preservatives in if they're known in the research to be so damaging?
It's mainly the price, if I'm honest. So it's the price, and it's that the hypomelos when it first came out was the best drop on the market, and the way to prolong its shelf life was to add a preservative to it. Whereas and it's now the cheapest. I think it's about, correct me if I'm wrong, it's about £1.90 per little vial of that. So it's mainly the price that goes into that factor there.
Okay, thank you.
No worries at all. So hyaluronic acid is more sort of the gold standard, which we recommend now to sodium hyaluronate because of its moisturizing capabilities as well. So not all eye drops are the same. So this is just some of the drops that you guys probably have seen on formularies as well. So you've got the hydroxypropylmethylcellulose, which is your hypomelos. You've got the carboxymethylcellulose, which is your cellulose. And then we've got a few preservatives as well. Can anyone name any of the preservatives? Can you spot any of the preservatives that might be in drops?
In glycol would be a preservative.
Okay, yeah. So we've got we've got that, and we've got cetrimide underneath it. We've got benzalkonium chloride. Benzalkonium chloride is more commonly found in hypomelos. So when you prescribe hypomelos, it's normally prescribed with BAC, which is the worst one. So that's the one that you least want as well. So yeah, not all eye drops are made the same. They're all slightly different, but one that we at the moment is the gold standard on the market is the sodium hyaluronate because of being natural and because it has such high moisturizing capabilities as well. But in the same stroke, not all sodium hyaluronidates are made the same as well. So what's so good about HA, hyaluronic acid? It's the way to do with the hyaluronic acid molecules are arranged. So hyaluronic acid is great as a product because it has really high moisturizing capabilities. But there's different types of hyaluronic acid that you can actually get. You can get cross-linked hyaluronic acid, which is all sort of scrunched up in a ball. You can get this low molecular weight short chain HA, which is a bit like short pasta if you think like penne. And then you've got like high molecular weight, long chain hyaluronic acid, which is a bit like long pasta. So they all would have different effects when they go into the eye. You cross-linked, if you think about the tear film, if you've got something that goes in and is really cross-linked, it's not really going to get into the matrix of the tear film, it's just sort of going to sit on top. You've got the low molecular weight, which is like short pasta. So it's going to get in there, but it's not going to get as deep because it's not as long. Whereas you've got the high molecular long chain HA, it's like long pasta, it gets all the way in and it attaches itself to that mucin layer. So that innermost layer that attaches to the cornea, and it stays in there for longer. So it has a longer retention time as well. So those patients that are having it will get that longer term relief if it's a high molecular weight, long chain HA. So it's also to do with the quality of the products as well as the molecules that are going inside of it as well. So Not all hyaluronic acids are made the same, so it's important just to be aware of which type even you're recommending of that. It's a minefield of drops. There's so many different drops out there, it's really hard to know which ones are which. So high molecular weight of hyaluronic acid, it holds more water, so it has more binding capability, so it can hold more water in the layers of the tear film, which is the main function really of a lubricant of the eyes as well. Hyaluronic acid, high molecular weight hyaluronic acid is better at treating underlying inflammation. So we all know dry eye is more an inflammatory condition, and molecular weight HA is better at treating that. So the high type, the long spaghetti type, displays anti-inflammatory properties, whereas the low molecular weights, like the short like penne or cross-linked one, is potent for its pro-inflammatory molecules, which is the opposite of what we want. We want the anti-inflammatory that's coming from that hyaluronic acid as well. And actually, high molecular hyaluronic acid has better, higher viscosity. So you could get two exact same drops. You could get a sodium hyaluronate, which is 0.2%, both exactly the same 0.2%. One could be long chain, one could be short chain, but the long chain one will have higher viscosity. It will have a longer retention time in that tear film, which is what we want from an eye drop. We want it to stay in the tear film as long as it can to provide the most moisture as well. So I'm just going to demonstrate this. So we've got a drop type with different types of hyaluronic acid or sodium hyaluronidates. So they're just going to go on to this little bit of acetate here. So these are all the same concentrations. And when it lifts up, you'll see that they all sort of fall at varying rates, whereas they're all sort of similar in terms of the concentrations as well. Like this is 0.4% hyaluronic acid, which is falling, whereas the 0.2% didn't fall. So it can make such a difference to the quality of the product, not just the concentration as well. So it's not always about the concentration of the products that you see. So high molecular weight hyaluronic acid is better. It's better at hydrating, at treating the underlying inflammation, and that better residence time in the eye, which is what we need really overall for a dry eye drop to help our patients as well. So what does that mean for our patients? We have some great products on the market already overall, and early detection and intervention mean that dry eye is potentially easier to manage as well. But if we proactively identify dry eye, it reduces the amount of number of patients that need specialist referral as well. So just coming across back to diet, for omega-3 and omega-6, you need a one-to-one balance between that. So an imbalance causes the oils to be thick and inflamed, and it prevents production of that lipid layer as well. So it's just important that we be having a holistic approach for our patients as well, letting them know to increase their diet and sort of the omega-3 acids as much as possible. So yes, so we've just got a few red flags just to add in the patients that you're seeing in clinic. So red eyes with dry eye disease, they don't tend to be sort of severe red eyes sort of constantly. They tend to sort of ebb and flow up and down. If you've got a patient that's come in with a red eye, especially unilaterally, you should be thinking of sending those patients to A&E, because that's not something that you could manage with in clinic with a dry eye drop. I've got an interesting one there on the left, which is a subconjunctival hemorrhage. Again, that's not dry eye disease. A lot of the time patients will experience dry eye symptoms with a subconjunctival hemorrhage, but that's something that needs to be seen by, if you guys are happy to look for the borders or an optometrist or sort of in A&E clinics. If you see anything like that, it's more referring it out rather than managing it in practice as well. We've got sensitivity to light or photophobia. With patients with dry eye, they won't experience severe sensitivity to light. So if you've got a patient coming in saying, listen, I've woken up in the morning, really, really sensitive to the light, that's not to do with dry eye disease. That's more likely to do with like anti-uveitis or a corneal ulcer. So again, that needs to be sent into A&E as well. Got a reduction in vision. Again, patients with dry eye disease don't normally associate with a reduced vision. It will clear when they blink. If they've got a severe reduced vision, that won't be to do with dry eye disease as well. And then pain. Patients don't normally tend to come with sort of severe pain with dry eye disease as well. It tends to be sort of very chronic, sort of dull pain. If they're experiencing sharp sort of pains in their eyes, again, refer out to A&E to have a look for that as well. And these are some of the differential diagnoses that you can see as well with patients that might have dry eye disease. You might think they have dry eye disease, some of the differential diagnoses. So you've got corneal ulcers or keratitis. So you've got that one in the top sort of left picture just there. You've got a little corneal ulcer there. So it's a bit like an open sore on the outer layer of the cornea. At first, it might sort of seem like conjunctivitis to the patient because it's a bit sort of sore, not completely like coming in with symptoms. And one of the risk factors for corneal ulcers is also severe dry eye as well. But if you're seeing sort of any sort of grey lesion on the cornea, or if they're coming in with photophobia, then you should think sort of corneal ulcer as well. We've got acute glaucoma. Patients will come in sort of with a really severe red, painful eye. They need to go sort of straight to A&E. If you think about a sink, and if you've got the plug in and it's building up with the pressure, that's exactly what acute glaucoma is like. That's all the pressure sort of building in their eye. So that needs to be seen immediately by a consultant so that they can relieve their pressure as well. Anterior uveitis, again, is to do with sort of inflammation. Those patients will present with more glare sensitivity to light. We've got severe sensitivity to light. Allergic conjunctivitis is more sort of like your itchy, really sore eyes. They need to be treated with, again, with allergy drops as well. Some of the things you might see is a recurrent corneal erasion. These are patients who are coming in with sort of really sore red eyes, especially when they wake up in the morning. What happens here is that when they open their eyes in the morning, they're basically ripping off the epithelium front surface of their eye off. So they're going to come with really painful, sore red eye immediately. It's going to be really severe. And then to do with herpes simplex keratitis, again, this is then a viral thing, and that needs to be seen immediately by A&Es. Yeah. So it's just about creating the management plan, recommending the most appropriate products based on the findings, and communicating the management plan, I think, is the most important thing with the dry eye patients, because they will use the drops for a few days and then they'll come back and they'll just say, oh, it's come back again. But they need to come back. They need to keep using the drops is the most important thing. Communication is the main thing here with your dry eye patients as well. Making them aware that they need to be using their drops, 4 or 5 times a day, and they need to continue with it. It's chronic. If they stop using it, all their symptoms will just come flooding back as well. And then I've just got a slide here on just scope environmental sustainability. It's really important, even when you're recommending drops, that you're thinking about the environment as well. A lot of drops come in just the single dose units, and some come in the multi-dose bottles. The multi-dose bottles are better for just the general environment as well, because they're not using a single dose plastic thing every single day, and minimizing sort of the packaging that you're using on that as well. So just doing sort of sustainable behaviors as well. So that's everything I have today. Thank you for listening. Does anyone have any questions?
Thank you so much, Indy. That was really, really useful. Thank you.
No worries at all.
On like medicated eye drops, like for glaucoma or for latanoprost or something like this, is there a like with hydrocortisone and emollients, we recommend at least half an hour between the medicated product and the moisturizer.
Yes, so we normally say about 15 minutes.
15, okay.
Yeah, to let the glaucoma drop absorb, and then they can put in the dry eye product afterwards. 15 to 30 minutes, yeah. So you just said about the cleansing products.
Yes, yeah, I wanted to ask that. Yeah.
There's a variety of different ones on the market. We've got the TTO lid cleansing. There's the lid cleansing wipes on the market as well. But there's a variety of different cleansing products that you can use specifically for blepharitis rather than baby shampoo.
How much are they? Do you know, Indy?
Nisha might be the best person.
Just because obviously baby shampoo is quite cheap to get a bottle and
it is, yeah. The thing,
yeah,
sorry, go ahead, Nisha.
I was going to say, because we used to in primary care promote the Optase tea tree oil lid wipes, and we stopped doing it in primary care. It's more the retail team that do it, but I think from what I remember, it's a box of 20 wipes. I think it's $6.95 or $9.95.
Is that the NHS? Is that the NHS?
Yeah.
And to get your patient to purchase them in clinic, I know in the opticians I work in, the 20 wipes are $12.95, or the TTO gel bottle is £9.99, but the bottle lasts for, if you use it every single day, it lasts 4 months, but it has a 12-month shelf life on it. So I understand what you're saying about the cost impact and they're using baby shampoo. But to be honest, baby shampoo is just ruining the tear film. So I always say to my patients, I've been using baby shampoo, look, I know you've been using it before and I know it's cheaper, but it's ruining the actual lipid layer of the tear film that we need to try and preserve. So this is an alternative that is basically for the eyes.
That's really interesting. Yeah,
would you just use the cleansing wipes for blepharitis, or can you just use it for, would you use it for just dry eyes without blepharitis?
You can do, there's no harm to it. It's great as a cleansing wipe. I use mine to take my mascara off, if I'm honest, because it's easy to do that way. But yeah, there's no harm to using it. It won't strip away any of the natural bacteria flora. It will just sort of get it to a normal level. It's always great to have nice clean eyelids.
It is, that's great. Yeah, I'll have to look on what's on our formulary when I get back. Great. Has anyone else got any other questions?
Sorry, just going back to the tea tree oiled wipes. If anybody is interested in samples, I can get hold of samples of that and send it across to anybody who wishes to try it out with the tea tree oiled wipes.
Brilliant. Well, if you don't mind, Nisha, then when if there is any information that we can forward out, any slides that are okay, or even just your email address, Nisha, we can send it out to the people who've attended today. Is that all right?
Yeah, I'm happy to share that slide again with my details in case anybody who joined on later didn't. Oh, brilliant. Yeah. So yeah, if anybody does want samples of any of the high-low range, Octays, tea tree or lid wipes, or information booklets, then there's my details. So just drop me an email and I can send you a sample request form, and I can arrange for the samples to be sent, whether it's to your practice or your home address. And yeah, that's not a problem. So do let me know and I'll arrange that for you.
Lovely, thank you. Has anyone else got any other questions? Real. Well, thank you everyone for coming. It's been really great, and thank you so much, Indy, for speaking. It's been really, really interesting
Thank you for having me.
Oh no, thank you for giving up your evening for us. So really, really appreciate it. It's so interesting to just go into one condition in detail. That's been really, really useful. So just a reminder for everyone, if just it's okay, I'm just going to stop your.
Oh, sorry. Yes, let me stop sharing.
No, not at all. I'm just going to pop on just to remind everybody some mandatory training coming up. So sometimes it's hard to make ourselves just go online when there's kind of no time pressure to do our child safeguarding and adult safeguarding. So if you would like to do it more live, we're doing those sessions in June and July, so you can log in, you can ask questions. They'll be way more interactive than just doing it on Bluestream or something, so please do come along to that. But thank you everyone for joining us this evening, and I hope you have a nice restful few hours.